I'm Jenny Patterson. I am the Director of Policy for the Office of MaineCare Services, and I am also very excited to have this process now coming to fruition and being able to have this public conversation.
Great. And David.
Sorry, couldn't find my mute button for a second. Good morning. I am David Jorgensen, the Director of Data Analytics and Rate Setting with MaineCare.
Okay, great. And I think that now is a good time to bring up the slides. All right, thank you very much. And you can move to the next slide. All right, so talking about the agenda for today's meeting, we are going to give a very brief overview of Chapter 639. If you have not read the law previously, I do encourage you to do so just because it is quite detailed and gives a great overview of how we will be and how we are setting MaineCare reimbursement rates going forward. As Jenny will get into a little bit more detail, part of Chapter 639, as I mentioned, brings into being this technical advisory panel, and it also calls for the department to annually share a rate determination schedule. Rate determination is the general phrase that we've defined in law that we use to talk about how we determine what rates should be for MaineCare services, whether that is through a rate study where we take kind of a building block approach to figuring out how much it costs to deliver service, or whether it is through a process of benchmarking existing rates, for example, Medicare rates, to determine what MaineCare reimbursement should be. So I'll talk a little bit about our goals specifically regarding the schedule for rate determinations. And then we're going to go through quite a list, what we have accomplished to date in terms of rate determinations, what we are working on or have planned that is required per legislation, efforts where we have already made public commitments to rate determination processes prior to Chapter 639 coming into effect, which was this past August. And then we get to the piece where we have the services that we are recommending as part of the annual schedule that we initiate those rate determinations starting through the end of calendar year 2023. And then we also have slides to share what services are remaining that will need to be scheduled as we move forward. We will discuss next steps and then have a short period of time for public comment. Next slide.
Just one housekeeping item. If you are one of our technical advisory panelists, you will be able to unmute yourself to participate in discussion as we're walking through the presentation. If you are not a panelist, you won't be able to unmute yourself, so you'll need to wait until that public comment period, and at that time you can raise your hand for comment, and we'll work through public comments at that time.
Great, thanks, David. We can move to the next slide, and we will introduce our technical advisory panel members, or have them introduce themselves. First, I'll make a few notes. Mark McInerney, who is from the Department of Labor, he unfortunately is not able to join us today. He is going to be, he's received materials about the meeting. He's going to be watching a recording and providing us with any consultation after the fact, and we will make public any input that he has as well. I also will note that the Office of Affordable Healthcare, we are supposed to have a member from the Office of Affordable Healthcare. That office is still in the process of being set up, so we don't have a person from that office to name to the TAP as of yet, but once we do, then we will. And I will also note that Joan Cohen will be joining. I'm not quite sure if she's here yet. She was anticipating she would be a few minutes late, but should be here once we get into the meat of the conversation. So with that, Karen Lee, will you introduce yourself?
Good morning, everybody. My name is Karen Lee Harrington, and I'm the Executive Director for the Maine Health Data Organization.
Thank you. And Marty?
Hi, I'm Marty Hooper. I'm the Life and Health Actuary at the Bureau of Insurance.
Thanks, Marty. We'll go to Heather.
Good morning, I'm Heather Hyatt. I'm one of the Associate Directors at the Division of Licensing and Certification within DHHS.
Thanks, Heather. And Amanda.
Good morning, I'm Amanda Rector. I use she, her pronouns. I am the state economist in the Department of Administrative and Financial Services.
Thank you, Amanda. And I don't think Joan is here yet, but in case I missed her. Okay, so once Joan joins, we will have her introduce herself as well. As David, I think, may have indicated, this is the first official meeting of the Technical Advisory Panel, and it is the meeting where, per Chapter 639, we receive consultation from the TAP regarding our annual rate determination schedule. And so that is why only the TAP members are able to mute and unmute themselves, because while this is a public meeting, it is really a meeting for discussion with those members, and we will have a period of time at the end for public comment. All right, so with that, I will look to Jenny Patterson to tell us a little bit more about Chapter 639. Jenny.
Great. Thank you, Michelle. Well, as Michelle said at the outset, we were so excited by the passage of Chapter 639 because it really reflects the culmination and also the beginning of our rate reform effort at MaineCare. So this law was passed in 2022. Basically, what it does is it creates one single standalone section of Maine law. So there's one place to go to that codifies the processes and principles for establishing MaineCare rates. And so one of the things that's exciting about it from our perspective is that it creates a clear process. So it requires us to set a schedule for regular review of rates and adjustment of rates. And it also requires us to look to sources that make sense for establishing those rates. So for rates that are benchmarked off of Medicare or other payers, there can be regular updates that reflect those benchmarks. And then for rates that are not benchmarked, there is an annual schedule of what we're calling rate determinations, which is the process by which we establish the rates. And so then if there is a service that is not on the rate determination schedule for a particular year, then that service will receive an annual cost adjustment. And so really it obligates us to look at data in establishing rates. So state and national data, and also looking at alternative payment models and whether those are appropriate for a particular service. One of the things that I think was strengthened during the legislative process was just the transparency of the process. And I think that's really reflected in the law that was passed. So there are public notice requirements, there are public presentation requirements, there are opportunities for comment on proposed rates, even independent of the rulemaking process. And it also really creates a connection to the MaineCare Advisory Committee's rate system subcommittee, which we've been working with really closely even prior to that passage, but it codifies that requirement. So next slide, please. Oh, sorry, the Technical Advisory Panel, it's on the bottom of my screen, so I don't see it. Sorry. It also crucially creates this Technical Advisory Panel, and it sets forth who needs to be on it, as you saw in the prior slide. So now next slide, please. So why we're here today, the law specifically requires MaineCare to consult annually with the Technical Advisory Panel to get input on the rate determination schedule. And so that's what we're doing today. So this is the consultation. And then we will be sharing the proposed schedule, posting it on our public website. We also have a public forum that's coming up for interested stakeholders to review it and to provide comments. And then after we receive those comments, we'll be putting a summary of comments on the public web page. And that also allows us to do off-schedule rate determinations as the department deems appropriate. But really, there's a focus on having this orderly process where we talk through what our priorities are. Next slide, and I think I'm passing it back to Michelle.
Thanks, Jenny. So I will be the first to say that when we were talking about getting out this annual schedule of rate determinations, we felt like, gosh, October feels late to be doing this. And just by way of an explanation, so Chapter 639 did not go into effect until early August. And then because of the requirements to consult with a technical advisory panel, we had to bring the technical advisory panel into being. And so as I'm sure folks can appreciate, especially when you're starting in August and there are vacations, et cetera, going through the process of naming individuals and making sure that they could participate and then getting folks oriented has taken a little bit of time. So we are hopeful that for our subsequent annual schedule conversations, we'll be able to start a bit earlier than we did this year. Speaking of our schedule to finalize our rate determination schedule for the year, this is our first official step today with our consultation with the TAP. We will be making these slides available, and we will be taking the consultation from the TAP members to make any amendments to the current recommendations. And we will post the resulting recommended rate determination schedule to our website starting, our goal is next week. We also, per Chapter 639, have a rate subcommittee of our MaineCare Advisory Committee, and the dates here reflect the currently scheduled dates of those meetings, which are determined by the subcommittee. And so we have time blocked out to have conversations with the MAC subcommittee. And then the week of October 20, or excuse me, the day of October 26th, which I think is a Wednesday, we have scheduled a public forum to talk about the rate determination schedule. So today is a public meeting, but as I've said, the purpose is for consultation with the TAP. We will reserve some minutes at the end for public comment, but the full forum on the 26th is when stakeholders will have more time to prepare and will be able to make any comments that they wish regarding the schedule. So we encourage you to utilize that time. We are looking at November 9th as a deadline to receive public comments regarding the proposed rate determination schedule. We will be summarizing and posting all of those comments the week of November 21st and looking to the week of December 5th to post a final annual rate determination schedule. And with that, I see that Joan has been able to join us. Joan, would you please introduce yourself to the group?
Hi, thank you so much. I'm Joan Cohen. I'm the deputy at the Department of Professional and Financial Regulation.
Thanks, Joan. And perfect timing because we were just finishing up getting through background, so you are here for the more substantive discussion. So I want to talk a little bit about our goals specifically for the rate determination schedule. So I've already said that for rate reform as a whole, we really aim to get to a point where all MaineCare reimbursement is equitable and adequate and data-driven. In terms of our goal for this schedule, if you have looked at Chapter 639 before, it lays out a process by which rates should be set for all services that are covered by MaineCare. But there is no magic wand that enables us to make sure that all rates are set that way immediately. And so we have been talking about this process as getting sections of policy, which is how MaineCare talks about its covered services, to baseline. And when we say to baseline, we're really meaning making sure that the rates for the services are getting determined through the process that is laid out in Chapter 639. And once that process has been carried out, or we have carried out that process for all services within a section, we consider that section to be at baseline for Chapter 639. Once the section is at baseline, then we get into our schedule for regular adjustments. So if rates were determined by a rate study, then there are annual COLA adjustments. If rates are benchmarked to a percentage of a Medicare rate, then there are those rates will be updated annually as Medicare rates are updated annually. And if we are benchmarking other rates, for example, other state Medicaid agency rates or commercial rates within the state of Maine, as an example, then we would be updating those benchmarks on a biannual basis. I will also say that this is consistent with the comprehensive rate system evaluation that the firm Myers and Stauffer performed for the department. They recommended, and we agree, that the same services should be reimbursed in the same manner and the same amount. And we have sections of policy where there are pieces of those sections across sections with similar services. And so you will see, as we're going through what we have done and what we plan to do, that sometimes we have a number of sections of policy all at once, but we're just looking at a subset of those services. And that's because we're trying to be consistent across sections of policy when we are determining reimbursement for like services. And I also will say that we are not going to pretend to be perfect. And even when we have gotten through a section and we say that that section is now at baseline, sure, there is room for improvement, no doubt. However, from an equity standpoint, and equity for providers directly translates into equity for members who are the most important beneficiaries of the services, and making sure that our rates are adequate to ensure access. Once we have gone through a section, we're not going to revisit that section until it's part of the regular schedule. So even if a year later we say, oh, we wish we had done this a different way, we really need to get all services to baseline before we start revisiting sections that we've already visited. Okay, next slide. So don't worry, I'm not going to go through everything on these slides. They're pretty dense. And as a reminder, what we're going to go through here is we're going to talk about what has already been accomplished to date. I don't want to spend a lot of time on these because it's already done. We're proud of it, but that's not why we're having this discussion today. Then we're going to talk about what we need to do because of legislation. Again, there can be some limited conversation there, but it's an area where for those items, we don't really have much of a choice because per law, we need to do those rate determinations. Then we have efforts where we made public commitments to conduct rate determinations prior to Chapter 639 going into effect. And then lastly, we have remaining services that we are recommending we get on the schedule to start rate initiations or to initiate rate determinations, through calendar year 2023, and what services are left over that we will need to schedule in the future. So that's the order of events. All right, so what has been accomplished so far? As I stated earlier, we started our rate reform efforts prior to Chapter 639. Back in early 2020, we were already making public commitments to having data-driven processes for updating rates. And the first set of services that we really started addressing were looking at our home and community-based service waivers, and starting in 2020, looking at home supports, community supports, and supported employment. This has really been a process of adjustments in 2020, 2021, and 2022, making sure that we were updating rate models and that we were providing labor components in those rates that supported a living wage. For all of those waiver services, the one remaining category of, I guess I'll say, sub-services that we have not gotten to yet is nursing and clinical services. And so that's really what's needed in order to bring those sections of policy to what we consider as baseline. Next, also starting in 2020 is when we started looking at personal care services, which likewise go across a number of sections of MaineCare policy as listed here on the left under policy section. So consumer-directed attendance services, home and community-based services for older adults and individuals with physical disabilities, and private duty nursing. And so we made changes to address substandard wages, frankly, starting in 2020. And then in 2022, per a piece of legislation that resulted in Part Quadruple A, we needed to update wages again to make sure that they were brought to at least 125% of minimum wage. And the last section of policy that really falls under personal care services is under a rate determination right now, and that is section 26. Any questions on that slide in terms of any clarification? All right, next slide, please. Okay, so that's supposed to, under effective date, it's supposed to say 2021, not 021. So sorry about that. Section 97, Appendix D is our coverage for children's residential care facilities. Those rates had not been addressed in, I think, a decade. And in addition to that, the federal government had a new, I think it's called Qualified Residential Treatment Program, so new quality standards that they were asking facilities to meet. And so to meet that next level of care and also to update sorely outdated rates, we implemented new rates for the service per a rate study in the fall of 2021. Per legislation, we addressed rates for ambulance services last spring just for Medicare codes within ambulance services and brought those into full alignment with how Medicare reimburses for ambulance services. And then dental services, July 2022, separate from rate reform explicitly, we expanded to provide comprehensive adult dental benefits. At the same time we were doing that, we updated reimbursement methodology for all of our dental services using as benchmarks Maine commercial rates as well as other state Medicaid agency rates. And so we consider dental services to now be at baseline with regards to Chapter 639. Any questions there? Okay, next slide. All right, so as shorthand for this long list of sections of policy, we call this our Medicare standardization group of services. And so essentially all of these sections of policy have services that are covered under Medicare. They already benchmarked a percent of Medicare, but they were, many of them, if not all of them, were looking at a year-long past. When new services got introduced, they were by default reimbursed more generously because they needed to look at a more recent Medicare year. So there was a lot of inconsistency and inequity in how these services were getting reimbursed, and the benchmark wasn't being updated annually. So as of July, we brought all of these sections of policy to benchmark current year Medicare, which will be updated annually, and standardize that percentage of Medicare to 72.4%. It's not indicated here, but for primary care services under Section 90 physician services, those are benchmarked to 100% given the importance of those preventive services. So that was tremendous work across all of those sections of policy. We also know that some of our most inadequate reimbursement in terms of comparing how we reimbursed with other state Medicaid agencies and Medicare were in these services. But we do still need to address the non-Medicare codes that are within these policies, which can be a messier and more time-intensive process. So those still remain to be updated. And then also Maine Mom, which stands for Maternal Opioid Misuse Program. This is a federal initiative where we were a grant recipient. It is a new service providing integrated opioid treatment as well as perinatal services for pregnant and postpartum people with opioid use disorder. And that rate was determined actually prior to Chapter 639 going into effect. We have federal authority and are still in the rulemaking process for those services. Questions?
Michelle, this is Karen Lee. I have one quick question, and I'm sorry if I missed this along the way, but what is a non-Medicare code?
So it is essentially a service that Medicare does not cover, but that MaineCare covers. So we can't benchmark a Medicare rate because one doesn't exist. And so we either need to find another rate to benchmark or do a rate study to determine appropriate reimbursement. Thanks for the question, Karen Lee. Okay, next slide. All right, so on this slide, these do not represent full rate determination efforts, but they certainly have had substantial impact to our rates. And so we do consider them to be part of our rate reform effort. I mentioned briefly Part Quadruple A, which was legislation to ensure that for essential workers, in a number of specified sections of policy within MaineCare, that we make sure that labor components of the rates are equal to at least 125% of minimum wage. And so that was really a tremendous work that continues today across many sections of policy, and policies that haven't already been mentioned in previous slides also include nursing facilities services and residential care facility services, which are also called private non-medical institution Appendix C. And then also, because we recognize that it takes time for us to get all of these services to baseline under Chapter 639, in the meantime, the department per Chapter 639 is providing COLA adjustments for services that have not otherwise received a cost of living adjustment within the past 12 months. And so that is just to at least, even if we haven't been able to get them to baseline, to start regularly adjusting rates as interim relief for some of those services that have not received rate adjustments in a long time. So those are all of the services listed there, where in July we started providing those cost of living adjustments for services that didn't already receive those as part of law. Any questions there?
This is Amanda. Just a quick question on the minimum wage adjustments. Do those adjust each year as minimum wage adjusts?
That's a great question. The answer is yes. So the January 2022 was when Part Quadruple A went into effect, and for all of the services that received rate adjustments for January 2022, they will receive another adjustment for this upcoming January 2023 to reflect the 125% of the new minimum wage. All right. I'm going to take a breath, and David Jorgensen is going to walk through the rate determination efforts that are driven by legislation. David.
Thanks, Michelle. So I'll just start by noting that that Part Quadruple A that required the 125% of minimum wage had two phases. Some sections of policy started getting those minimum wage adjustments in January of 22, and some of these sections started will start in January of 23. So those are reflected here. We have initiated rate determinations for adult family care homes, AFCHs, and day health services, which the same members often receive both of those services. And across these behavioral health sections of policy as well. Those are subject to Part Quadruple A if there are any services where that minimum wage adjustment might have an impact. We have focused a lot of effort on behavioral health and making sure we're looking at appropriate levels of care. So psychiatric residential treatment facilities, we do not currently have any enrolled providers for PRTFs currently in MaineCare in the state of Maine. So we are looking at updating those rates to help us with recruitment efforts to get those providers on board in the state. We have targeted case management, kind of fits into that same behavioral health services bucket, and DME has been long overdue for rate updates. This is kind of in the same vein that those Medicare standardization codes were often very outdated because they were referencing a very old, obsolete Medicare fee schedule year. So we will be updating those rates to current year Medicare and updating that percent of Medicare benchmark up to 100% of Medicare. With that comes changes to Medicare pays differential rates for rural and non-rural member addresses, because there are large pieces of equipment that need to be delivered to those areas that cost a little bit extra if they're in a non-rural, or sorry, if they're in a rural setting. And this has the same issue where there are non-Medicare codes where we cover a more extensive list of services than Medicare does. For those services, we won't do a full rate determination. We'll just provide a cost of living adjustment for this January, and we'll have to follow up with a more robust, complete rate determination for those. In the last legislative session, a bill was passed that requires MaineCare to rebase all of our FQHCs. So that project is already underway. And we've also, we're also required to update just the discharge rates for distinct psychiatric units. Right now, those services are often individual facilities get their own rate in legislation, which is not necessarily a very data-driven way to reimburse those hospitals. So we're looking at concerns with that reimbursement rate to make sure that we can address concerns of being able to pay for acuity and length of stay in a way that hasn't really been addressed before. Sorry, before I move on, any questions about that last slide? So these projects are not yet underway, but we have planned them, and they are tied to legislation. So looking at expanding services to include palliative care services. This falls under our home and community-based services plan that has received funding from the 9817 section of the American Rescue Plan. Along with our other behavioral health service reforms, we are updating our opioid health homes to include models for services tied to other substances, so not just opioids. So those models will be more inclusive of other substance use disorders. And dental has been mentioned because dental is based on commercial payment benchmarks. That has to be updated every 2 years. So that work will just start right at the end of calendar year 2023. And so that's listed here to reflect that requirement to update those benchmarks. As Michelle mentioned, that's already at baseline, so it shouldn't be significant reform at this point, just a benchmark update. Questions on this slide? So these sections here are not necessarily required by any legislation, but we have made public commitments to address these services. And so these are very high priorities. They've been high priorities, and we feel a strong need to address those. Behavioral health homes we're making all of these reforms mandated by legislation to other behavioral health services, and behavioral health homes more or less are the alternative payment methods that kind of bundle together groups of behavioral health services. So if we're updating all of our other behavioral health services, we really do need to update the behavioral health home model as well to make sure that the rates are equitable for these providers and not just the providers receiving fee-for-service payments. We are looking at expanding services to include the National Diabetes Prevention Program model. So that will be starting fairly soon. And then along with our psychiatric discharge rates, we want to make sure that all reimbursement for hospitals is data-driven and makes sense. It's been quite a while since we've rebased our DRGs, for example. And so we'll need to do some extensive research to make sure that we can update those reimbursement models appropriately. And last on this slide here, there is a new service that we would like to add to section 23. This is a requirement that we establish a comprehensive assessment at the time that a child enters state custody. So MaineCare should be reimbursing for that comprehensive health assessment. And that will be a new service. So it's officially a new rate determination, but it is just a single service to kind of flesh out that full section 23 set of services. Any questions on this slide? All right, so continuing to follow through on public commitments, these are areas where we've already initiated work. We've written an RFP, we've begun the procurement process to secure a vendor to work on these rate determinations. So I guess those vendors haven't been secured yet, but they are in progress, and so the rate initiation hasn't been formalized, but it's underway internally in that procurement process. So nursing facilities and residential care facilities, this is PNMI, private non-medical institutions, Appendix C, provide a fairly similar set of services for members who require somewhat different levels of care. Nursing facility level of care is a little bit more intensive than the residential care facilities level of care. So there's a lot of big, complicated methodologies that are currently in place. This includes cost settlement and the quadruple A minimum wage adjustments that were passed through legislation. So there's a lot of piecemeal approaches currently to reimbursing these facilities, and it's been administratively burdensome, not just for MaineCare in the department, but for the facilities themselves as well. So we'll be kicking off a rate determination for both of these sections to ensure that we can set data-driven rates and include those alternative payment methods that incent quality of care and reward cost effectiveness for facilities that achieve those higher standards. Likewise, family planning, they had received some minor updates for Medicare standardization. If there's a handful of codes that relied on that had a Medicare rate, many of the services though that family planning provides are not covered by Medicare. So we are looking at how best to provide reimbursement for those family planning services. And there's quite a bit of complexity around that. So we are beginning that procurement process to work with the vendor to dig into that. Any questions on this slide? All right, and these are, again, more public commitments. We are looking at our primary care plus. This is kind of an evolution of some previous alternative payment methods are being rolled together. Our health homes and our PC PIP program have kind of merged into this primary care plus program. So that is a big investment in primary care services and leveraging alternative payment models to get the best quality for those primary care services. Certified community behavioral health clinics, CCBHCs, is another kind of tier of care for within behavioral health services. And we think that it's important to continue to flesh out our behavioral health models to include this model as well. And then, as Michelle mentioned before, in sections 20, 21, and 29, we do still need to look at making rate adjustments for sleep staff and multiple person shared living rates within those HCBS services. Any
David,
questions?
I'll briefly note on the last row there that during the pandemic, we have had some flexibility from the federal government, and we utilized that flexibility to make some changes to support multiple person shared living within these sections of policy. But that authority, because it was tied to the pandemic, once the public health emergency officially ends, 6 months later, our ability to continue those adjustments also end. And so there's been consensus that we want that flexibility to continue, which means that we need to go through a formal process to make that happen. So just a little bit more context on what that entails.
Thanks, Michelle.
David, this is Karen Lee, can I just ask one quick question?
Sure.
All the other benefits, seem relatively straightforward if you know anything about some of these things, but what is multiple person shared living? Like what is that? Just really quickly, I don't want to take a ton of time because I probably don't need to know all the details, but just curious what it is.
Do you want me to take a stab at that, David?
Yeah, please.
For individuals who receive services under our home and community-based services waivers, some of those individuals maybe might live with a family. So instead of, for example, living on their own or living in a group home, they live with a family. It may not be their own family. And so this is support to the family, as well as the kind of administrative things that need to happen to enable that individual to live in the community with a family. There was recognition that I think previously, actually, a family was not able to have more than one waiver participant living with them. And we wanted to change that because it just makes sense and is more flexible. And some individuals want to have a peer who is living with them as well. And so we needed to make that an option and also determine what reimbursement was appropriate when you have more than one individual in that shared living situation.
All right, any other questions before I move on? Let's see, Michelle, I think we are passing this over to you now.
Yes. All right, so we've gotten through what we've done and what we have to do and what we've committed to doing already. And now we are at the place where we are talking about other services that the department is recommending be on our schedule through calendar year 2023 to get these rate determinations started. These are the 4 services that we are recommending also be on the schedule. And we go into detail or more detail on each of these services in the next slides. We can move on, Mandy. All right, so the first service is therapeutic foster care. This is the one service that remains under Section 97, Appendix D that we have not yet addressed. This is, it's a family-based model for kids who are currently in Health and Human Services custody. These kids have behavioral and/or developmental needs, I guess I would say require another level of therapeutic care in order to be able to keep these kids in homes in the communities rather than turning to more institutional levels of care. We have provided a cost of living adjustment for these services, but the last time that there was a more meaningful look at rates was back in 2016. This is also one of those sections of policy where we actually don't have a record of how the rate was arrived at to start with. That is something that we are intending to fix for all services under Chapter 639. I'll say that part of our comprehensive rate system evaluation, with all the plethora of services, our vendor actually that conducted that evaluation did not actually realize that there was a separate therapeutic foster care component of this section. So it wasn't really prioritized in that evaluation. This summer, there was a press release that went out that the United States Department of Justice has found that Maine's children's behavioral health services that are community-based are lacking and that there is too much reliance on residential facilities and institutions. The DOJ specifically calls out that there is currently a lack of support for foster care parents who provide specialized care to kids with high needs. And so that is why we feel it is very much a priority for us to take another look at this service to make sure that we are providing adequate supports to be able to serve these high needs kids and keep them in the community. Questions or comments about this service and recommendation? Okay, next slide. So the next two slides go together, but it was too much information to put onto a single slide. So section 97, it's a broad section that is somewhat unhelpfully called private non-medical institutions, which is an old term that we should probably update. There are two appendices within that section of policy where we are recommending that we update the reimbursement before the end of calendar year 2023. Those are appendices E and F. Appendix E, those are community residences for persons with mental illness. So kind of think about a kind of smaller group home model, but for individuals often with serious mental illness who need a residence. They also need mental health treatment. Those facilities are licensed by the department. The Office of Behavioral Health helps oversee those facilities. So currently those rates are really based on budget submission and review. When you don't have a standard rate methodology that is tied to standard expectations or requirements, what often happens is you end up with a lot of variability in rates, and that variability is not necessarily tied to differences in patient need or differences in services. It might be, but we also, and when I say we, I mean, this is just kind of a question of economics, like you find that there's a lot of variation, and some of that variation is unwarranted, and there's also not an incentive with this kind of methodology. The reimbursement is not tied to quality of care. There are not incentives for cost effectiveness if you know that you're just going to get your costs reimbursed, regardless of what they are. So we try to review for reasonableness, but do not feel that this is a recommended reimbursement methodology, generally speaking. I will also say that these PNMIEs, we've had a lot of discussion about how they really serve individuals with a broad diversity of needs. And so we're also interested in having a service model and a reimbursement methodology for that service model that better reflects that diversity of needs without having to do home specific reinventing what the reimbursement should be on a regular basis. And I'll talk through the next slide on Appendix F before we take questions or comments here. So Appendix F, still think about that, community-based, smaller group home model. This kind of facility is for members who have specific diagnoses such as acquired brain injury, HIV/AIDS, intellectual or developmental disability, or blindness. So pretty high needs individuals who are not eligible for services or including residential services under our home and community-based waivers. So these services are mostly reimbursed through cost settlements based on cost reports. We've already talked about the downsides of that reimbursement methodology. And similar to Appendix E, there's also a lot of folks with different needs in this model, and we think that we should address both of these models at the same time. We know that there's some actual overlap between members who may be served in these and expectations for those facilities. And so our recommendation is to do a rate study for both of these models concurrently. Questions about the Appendix E and F recommendation or service or comments? All right. Moving on then. Okay, so we briefly mentioned this when we were talking about sections of policy where we had already addressed a number of services. So for a number of our home and community-based waivers, as well as a number of our policies that touch on personal care services, there are components of those services that are really nursing services and clinical services. Think physical, occupational therapy, speech therapy. So that kind of nursing and clinical level of care across those sections of policy, we have not addressed the rates for those services. You can see here that depending on the specific section, it was as far back as 2010 when we looked at these rates, or as recently as 2019. We have heard a lot, both within the state of Maine as well as nationally, about labor shortages for nursing. We hear a lot about labor shortages across many healthcare services covered by MaineCare, but I think it's safe to say we hear the most about nursing. And also, as we have looked at utilization trends, while we would have hoped and maybe expected that home and community-based nursing would have increased during the pandemic, we saw instead pretty substantial decreases, which was worrying to us. And again, we know that some of these rates were long overdue for being updated anyway, and then you put the labor shortage on top of that. And then you also consider that some of these services were never reimbursed at a similar level in these home and community-based settings as they were in other settings, for example, in hospitals or clinics. And that is why we are putting these services on the list. Some of these services do have older rate studies as the underlying methodology, but then there's also sections of policy where we don't have a record of how the initial rates were determined. And we think that there is also good opportunity here to see where some of these services are the same as services reimbursed by Medicare. And so it might make sense to just benchmark some of these services instead of coming up with that kind of building block approach to figuring out what the rate should be. Comments or questions on these services? All right. And then lastly, in terms of services we're recommending be on the schedule through calendar year 2023 is community paramedicine. This would be a new service. There has actually been conversation within the state of Maine of trying to encourage a community paramedicine approach. Those conversations have been happening, I think, for a good decade. I actually remember back in the early 2010s, joining a conversation to get this effort started. It's really, the concept is really, let's use an existing emergency medical technician workforce, riding ambulances or smaller vehicles that are available. They get a special certification and they become a mobile workforce that can, especially in rural areas, help fill in gaps in care. So instead of an individual in a very rural area who's otherwise not mobile, really having to rely on, getting taken to the emergency department, this could be a wellness check, it could be basic preventive services, behavioral health may be an option. So we currently have a health equity grant through Maine CDC in partnership with EMS to develop this model and to collect data to determine what should the model look like and what should the reimbursement be for the model. Okay, any questions on community paramedicine? So I did want to take a bit of a pause here. I know that the members of the TAP come from different backgrounds. It would be helpful to hear whether or not some of what you have heard in your day-to-day jobs reinforces the need for any of these recommendations or reinforces, the department's current view of challenges with workforce access. And it would be great if you could share some of your reactions regarding these.
I'm happy to talk a little bit sort of broadly about some of the employment stuff. And I imagine Mark will probably have some comments on that front too, because he has more of the detailed information. But certainly, looking at employment across the sectors, healthcare has been struggling to recover from the dip that happened at the start of the pandemic. Most of the other sectors have recovered. And I think certainly given what's been happening with wage increases across all the different industry sectors, that could play into why that sector has been struggling. And certainly there was a lot of challenge pre-pandemic in getting adequate workforce in some of the healthcare sectors, and wages being a part of that. I think that was, I think in terms of the recommendations, the pieces related to trying to identify the labor shortages and the wage component of that, in terms of how that gets reimbursed, I think that resonated with me as being one of the things that is certainly from a higher level perspective, an issue that has been going on for some time now and was exacerbated by the pandemic and by things that have happened since then.
And for those of you who may hear more about healthcare experience, not just on the Medicaid side, but on the commercial side, if you have any information or comments you'd like to share about whether similar challenges you've heard on the commercial side or different challenges, might be helpful to hear that.
I would say from a facility licensing perspective, I like seeing recognition about the diversity of needs that need to be met in these private non-medical institutions. And there is a real lack of, I think, rates reflecting that we are expecting nursing and clinical services to be taking place in these settings, probably at rates that are not equitable to where nursing services are offered in other settings.
Thanks, Heather. Karen, Lee, or Joan, anything to add? Marty?
I'll just add something which is not going to be helpful to the conversation, but probably should have included in my introduction, which is licensing is independent of reimbursement. So, our participation really isn't about, can't be construed as an analysis of reimbursement as it affects any of our licensed professionals. I mean, I can certainly talk about what I've read and, in blogs, et cetera, but it's important to know that licensure is independent of reimbursement.
Thanks, Joan. I do think that it may be helpful at times to hear from your perspective of the challenges you hear about from those licensed professions regarding that there may or may not always be a direct tie to reimbursement challenges, but the broader context I think is helpful for folks to hear about.
And Michelle, I'll just say quickly, I'm not sure if this is helpful or not, but folks have been accessing our data for years to look at, to measure differences in reimbursement between commercial, Medicare, Medicaid. The RAND group has done quite an extensive analysis looking at what commercial payers are paying as a percentage of Medicare within the hospital system nationally, so our data has been I think, although not perfect, it's still one of the best data sources to look at these sorts of things. And as my father used to say, you don't know what you can't measure, right? I mean, so I think to your earlier point about one of your guiding principles is data-driven. I know our data, you guys have access to help with some of your work around the dental. So however we can help support the conversation from a data standpoint, we're here to help with that. And then, of course, there have been a number of bills that have been introduced over the last several years looking at how can we make more investments in certain sectors of healthcare, whether it be primary care, behavioral health care. And although those things haven't passed, I think what they have led to is looking at using the data to understand what are we spending on primary care, what are we, so, it's clearly an issue across the board, and it's just trying to figure out how to take all of these puzzle pieces, right, and put them together so that we can continue to support a comprehensive delivery system that is, as you said, equitable, data-driven, and I'm missing that third piece, adequate.
Thanks, Karen Lee. So I am going to turn next to, we have 3 slides that go through the services that we are not currently recommending go on the schedule for us to get started on before the end of calendar year 2023. First, I will just acknowledge that this is hard. I think that you can all appreciate that the list of rate determinations we have going on currently is very substantial, and that reflects the fact that we have a hard time saying this service should go before that service. And I will also note that within state government we have constrained resources, and we need to go through the actual rate determination process as well as get federal and state authority for all of these changes. And so we also need to think about our staff capacity, that also for some services, especially when we're changing the methodology and not just a rate dollar amount, means systems changes that we need to consider as well. And so that is my way of saying we can only do so much. We are committed to getting all services to baseline by the end of fiscal year 26. So what we still have on the list, you can see here, ambulatory care clinic services. Of note within this section is especially school health clinics. We are developing a new school health related services policy, and see this as belonging in that policy and recognize that we need to address those rates for school health clinics specifically as well. Ambulance services, we already mentioned that we have not yet been able to address the non-Medicare codes within that section. Freestanding dialysis. Medicaid, this is mostly a service supported by Medicare, but there are some instances where Medicaid reimburses as well. I'll just say that this section needs some cleanup and clarity in terms of reimbursement methodology and amounts. I'm going to go through the 3 slides before I pause. So let's go to the next one. We also already mentioned this first row. These are all of the services where we updated long overdue and standardized the benchmark to Medicare. But again, there are services within each of these sections of policy that are not benchmarked to Medicare, and those services need cleanup and adjustment as well. Section 23, we mentioned, this is where we are required to develop a new foster care health assessment rate. We also need to address the rest of this section of policy and also see whether or not Medicare may be a useful or appropriate benchmark for that service. Hospice, those rates are currently updated annually, but there's some differences in methodology between how Medicare approaches the service and how we approach the service. And so we want to assess whether or not changes are appropriate there in comparison to the rates that CMS publishes. Next slide. All right, section 50, this is intermediate care facilities for individuals with intellectual disabilities. Those rates are currently updated annually, but the methodology is very out of date. It's another one of those services where there really are not incentives for either quality or cost efficiency, and it relies partly on budgets and cost settlement. Section 55 laboratory services. This does benchmark Medicare right now, but it benchmarks an old year. This is an area where Medicare has actually implemented a number of decreases, and we were uncertain about the impact there, which is why we hadn't initially rolled it into the rest of the sections of policy that we're benchmarking Medicare, but recognize that we need to bring consistency to that service. Our durable medical equipment, we also already mentioned this. You'll notice a theme here where it's much easier to address where we're benchmarking Medicare than it is to look at the codes where there is not a Medicare benchmark and do more thoughtful analysis to figure out what the right approach is for those non-Medicare codes. So that is the case here also. And then I will mention that we have a model of care called a community care team. These teams often work with primary care practices for members who have high utilization of inpatient hospital services or emergency department care, and really require some intensive care coordination services so that they are getting their needs met, essentially. And that is a rate that is overdue for updating, and we're considering whether or not there are enough similarities between that service and some of what we're trying to do with our palliative care initiatives or PC+, where we could address that service also. Any questions or comments regarding these services that we know that we need to address and are looking forward to doing so, but we do not have on the list for calendar year 2023.
Michelle, I have just one quick question, and it's just because of some work that we did to help support the analytic needs. And it's back up on the ambulance. I don't know if you can go back a few slides. So I'm not sure if this is helpful or not, but we had provided a whole bunch of data to this work group that was created as a result of, I think it was boy, I'm not going to remember. I'm trying to pull up as I talk to you. I think it was LD 2105. And it had to do with, it was a report that went to the HCIFS committee, and it was looking at, you know, sort of ambulance providers in the state and reimbursement rates and this and that. And there were a whole lot of recommendations in that report. And there were some that were specific to MaineCare. I don't know. I just wanted to throw that out there. I don't know if you guys are familiar with that work and all the analysis that we've done, but I'm happy to share. We had put together a whole bunch of Tableau reports. And if it would be helpful, we could update, I think, some of that reporting relatively easily.
That would be great, Karen Lee. Yes, I think we learned about that group after the fact, and would have been happy to be involved in it, but would absolutely like to take advantage of the findings of the group. Thanks. Any other questions or comments from our TAP members on these services? All right, so for just a moment, I'll go back to our timeline for finalization of the rate determination schedule. And this is just to note that we are going to be posting these slides. We'll reconvene as well as get Mark McInerney's consultative feedback to determine whether we want or should make any changes to what we've recommended so far. So we will be posting information for the general public regarding these recommendations in preparation for a stakeholder forum on October 26th. where that is solely to hear from anyone who has comments that they would like to share regarding these recommendations or about the process generally. So having said that, for members of the public who would like to make a comment today, we have 9 minutes remaining. And if you could raise your hand, then we'll try to go in order of raised hands. And I do ask that you keep comments relatively brief since we have short time, but want to give an opportunity for folks as they see fit. Anne. I think, there we go.
Hello. Hello. To the extent that one has any procedural questions during the course of this process, is there a particular person in this group that would be the appropriate contact?
Yes, thank you, Anne. And actually, Mandy, if you could go back to that slide that you just took down, I think that's a helpful slide to answer that question. And David, I'm going to actually let you answer the question of who procedural questions should go to.
Yes, I think that Mandy is probably the best person to have outreach to on procedural questions. Her role is the rate setting coordinator. She coordinates all of the materials, helping with these slide decks and any communications we need to put together. So feel free to reach out to Mandy. If you would like to include myself and Peter on the CC line, that is fine as well, and that will draw that to our attention. But Mandy's best suited as that single point of contact to kind of aggregate that and follow up with the appropriate people.
And I just wanted to clarify that I do go by Mandy, but it's Amanda Lee.
Right.
Yeah. Jenny?
Yep, I just wanted to add for clarity, because we didn't get into detail due to lack of time, the rate setting process is distinct from the policy adoption process. So there's all of the contexts that were just identified are for the rate setting process. And then when we go into the rulemaking process, there will be a separate public engagement process and separate context during that process. And I lead that team. So if there's questions about that, you're welcome to reach out to me.
Thanks, Jenny, for that clarification. Any other comments or questions from the public? I will say that this resource slide also provides a link. When we post it, you'll have the link to Chapter 639. I will note that a number of us learned something new this week, which is that public laws never have even year numbers. So even though this law did not go into effect until August of 2022, the appropriate citation, which we missed on this page, is actually PL 2021, which is very confusing, but that is apparently how we do things in Maine, and we had missed that previously. So that is the link to Chapter 639, the MaineCare Benefits Manual. If you have a question about what a service is, who does it serve, what is the current reimbursement, what are the requirements for providers, that MaineCare Benefits Manual link is the answer to all of your questions. Those are the, when we say we go through rulemaking, that is where everything that goes through rulemaking ends up. And then we have our MaineCare Rate System Reform website, which is the repository for this information. And we are working on updating that website. It was initially a landing page really about our evaluation, but we are working on updating that so it is an easier repository for our new Chapter 639 process and all those associated documents. We will be sending e-messages once we have information posted for the next step in the process. All right, any other comments? All right, thank you everyone for joining us this morning. Thank you to the members of the technical advisory panel, and have a good Thursday. Appreciate your time.